Your patient is suddenly gasping for air. It hit out of nowhere. You listen, and the lungs are clear, both sides moving. The chest film comes back normal. And yet her oxygen will not come up, and her heart is racing at 120. Clear lungs, a normal picture, and she still cannot breathe. A clot has broken loose and lodged in her lung. What is your priority? Here is your question. A postoperative client suddenly develops shortness of breath, pleuritic chest pain, a heart rate of 118, and an oxygen saturation of 86% despite supplemental oxygen. The lungs are clear. A pulmonary embolism is suspected. Which action is the priority? A. Start anticoagulation with heparin, as ordered. B. Obtain a D-dimer and a CT scan before any treatment. C. Place the client flat, in Trendelenburg. D. Give a bronchodilator. Pause, and commit. 3, 2, 1. The answer is A. Start the anticoagulation. A pulmonary embolism is a clot blocking blood flow through the lung. And heparin does the one thing that changes the course. It stops the clot from growing, and stops new clots from forming, while the body dissolves what is there. The oxygen supports her. The heparin treats her. And when suspicion is this high, you do not wait for a scan to start it. Here is what is happening. A clot, usually from a deep vein in the leg, breaks free and travels up through the heart and into the lung, where it wedges in a pulmonary artery. Now blood cannot reach that part of the lung. Air arrives, but no blood flows past to pick up the oxygen, so the saturation falls, and adding more oxygen barely helps, because the problem is not air, it is blood flow. And the right side of the heart strains against the blockage. So one thing divides the whole approach: the blood pressure. Most pulmonary embolisms are stable, the pressure holds, and there, anticoagulation is the answer, heparin to halt the clot while the body clears it. But a massive embolism drops the pressure, the right heart fails against the obstruction, and that patient is in shock. For them, anticoagulation alone is not enough. They need a clot buster. To dissolve the clot now, the pressure tells you which. So here is the order. First, support. Oxygen, sit them upright, get IV access, and put them on the monitor. Second, anticoagulate heparin, as ordered, as long as there is no contraindication, to stop the clot from growing. Third, escalate if it turns massive, for a patient who becomes hypotensive, thrombolytics, or a surgical embolectomy. Support, treat, and be ready to escalate. Here is the rule. An acute pulmonary embolism with stable vitals gets oxygen and anticoagulation, and when your suspicion is high, you do not delay the heparin for a scan. If the pressure drops, you escalate to a clot buster. Anticoagulate the stable. Thrombolize the crashing. So how do you know a pulmonary embolism has turned dangerous? Watch the red flags: a dropping blood pressure, a systolic under 90, signs of shock, cool and mottled skin, strain on the right heart, a fainting spell, a saturation that stays low no matter the oxygen, and a rising troponin. A stable embolism is treated with anticoagulation, but any of those means massive, and massive earns the clot buster. 2 moves, side by side. Oxygen lifts the saturation and keeps her comfortable, but it does nothing to the clot itself. The block in the blood flow is still there. Anticoagulation is what treats the disease, halting the clot's growth so the body can dissolve it, but it will not raise a low saturation on its own. So you give both: oxygen for the breathing, heparin for the clot. One is comfort, the other is the cure. Now 2 instincts that go wrong. First, waiting to confirm. It feels careful to hold treatment until the CT proves it, but with high suspicion and no contraindication, every minute without anticoagulation is a minute the clot can grow. You treat and confirm together. Second, lying her flat. A patient fighting for breath needs to sit up, in semi-Fowler's. Flat, or head down in Trendelenburg, only makes the breathing worse. 2. To lock in. Why do these clots form? Virchow's Triad: stasis from immobility, long flights, or bed rest; hypercoagulability from cancer, pregnancy, and the endothelial injury. Treat, escalate, oxygen and upright anticoagulate with heparin. And thrombolytics if the pressure drops. Now the wrong answers. B. Get the D-dimer and the CT first. Confirming feels right, but you do not withhold ordered anticoagulation, at high suspicion, to wait for a picture. You treat and image together. That is the trap. C. Lie the client flat, in Trendelenburg. A breathless patient needs to be upright, not flat. This makes it worse. And D. A bronchodilator. The lungs are clear, there is no wheeze, no bronchospasm. A bronchodilator does nothing to a clot in the artery. Tie it together. Your cues: sudden shortness of breath, pleuritic pain, a racing heart, a saturation that stays low on oxygen, clear lungs, and a recent surgery or immobility. Your action: oxygen and sit them up. Start anticoagulation as ordered. Escalate to a clot buster if the pressure falls. And confirm with a scan alongside. And the outcomes you want. The clot stopped from growing. The oxygen supported. The clot dissolved over time. And escalation ready if she crashes. Now test yourself. Same embolism, but now the blood pressure crashes to 78/40, and she is cold and mottled, in shock. Is heparin still enough? No. This is a massive pulmonary embolism, the right heart failing against the clot. Anticoagulation alone cannot act fast enough. This one needs a clot buster, thrombolytics, to dissolve the clot right now, or a surgical embolectomy. What changed was not the clot, it was the blood pressure. One more. Same stable embolism, but this client is 3 days out from major surgery and actively bleeding. Heparin is ordered. Do you give it? No. Active bleeding is a contraindication to anticoagulation. The heparin could be catastrophic. When you cannot anticoagulate, the answer is an inferior vena cava filter, a device that catches clots before they reach the lung. Same embolism, but the bleeding changed the tool. Always check for a reason not to anticoagulate. One last patient. She is on heparin for her embolism, doing well, and on day 5 the platelet count falls sharply. Do you keep the heparin running? No. A sudden drop in platelets on heparin is heparin-induced thrombocytopenia, and paradoxically, it causes clots, not just bleeding. You stop the heparin at once and switch to a different anticoagulant, like argatroban. The drug that was treating her is now the danger. Watch the platelets on every heparin drip. Next episode. A fever spiking to 103. A heart racing, a blood pressure falling, the skin going mottled, and the mind going cloudy. The lactate is climbing. Infection is tipping into shock, and a 1-hour clock has started. One thing must happen before the antibiotics, and yet the antibiotics cannot wait. What is the order? That is episode 15.